Good morning, good afternoon, good evening to our guest speakers, colleagues, friends. Welcome to the MTaPS Global Learning Series Roundtable. I'm your host and moderator, Andrei Zagorsky, Senior Principal Technical Advisor and the COVID Response Team Lead for MTaPS. Today's webinar topic is Building Resilient Health Systems, what COVID-19 has taught us about infection prevention control and emergency supply chain. Let's take a quick look at the agenda. We will have opening remarks from the MTaPS leadership and then a brief overview of the MTaPS COVID-19 response, followed by moderated roundtable discussion and capped off with live questions and answer session. And we'll end up with some closing remarks. Now, before we begin, a few reminders. We're recording this session. Please turn on your video when speaking and do ask questions in the chat. We will answer them during the Q&A. With this, I'd like to invite Nicole Warczykovsky to provide opening remarks. Nicole is the MTaPS Deputy Program Director and leads our portfolios in 18 countries where the MTaPS program is implemented. Over to you, Nicole.
Hi, everyone, and thank you very much, Andrei. Management Sciences for Health as the prime of the USAID Medicines, Technologies, and Pharmaceutical Services Program, also known as MTaPS. For decades, MSH has supported governments around the world in building resilient health systems that have the sustainable capabilities to take coordinated, measurable actions to prevent epidemics, detect biological threats early, and respond rapidly to disease outbreaks. MSH has collaborated with a wide range of government, civil society, and private sector partners to build capacities in advocacy and coalition building, and to provide training in disaster preparedness and improve emergency communications outreach. From its inception in 2018, the MTaPS program was selected by USAID to receive Global Health Security Agenda funding and serve as a flagship mechanism for antimicrobial resistance interventions, including technical assistance to countries in improving multi-sectoral coordination, antimicrobial stewardship, and infection prevention and control. MTaPS currently supports the Global Health Security Agenda in 14 countries. We will hear more today from the MTaPS team and from partners and donors on how the MTaPS Global Health Security Agenda experience define the MTaPS scope and the COVID-19 response interventions at the country level. It is important to keep in mind that even when providing emergency technical assistance, MTaPS stands by the fundamental principles of health system strengthening, ensuring that interventions and innovations create sustainable human capacity and system elements that will contribute to lasting overall improvements in health systems performance. We hope that COVID-19 pandemic will eventually subside and there will be a recovery phase for countries and their health systems. Programs and organizations that previously had system strengthening as a backbone to their work in countries will have accumulated valuable and distilled experiences and new lessons and methods for strengthening health systems in a much faster and more efficient way. Today, through this webinar, we will share some of the MTaPS experiences. We thank you all for participating today. And now I'll hand this back over to Andrei to lead us through the program. Thank you so much.
Thank you very much, Nicole. And let me expand on Nicole's opening remarks by providing a more detailed overview of the scope of the MTaPS COVID-19 emergency response technical assistance. As Nicole said, MTaPS has been USAID flagship program in 14 countries for the global health security agenda since 2018. And those two components that were implemented through GHSA came in as very important ones during the development of pandemic response. So the MTaPS GHSA experience in IPC defined the entire MTaPS COVID-19 scope when it was declared a global emergency in early 2020. And that included enhancing multi-sectoral coordination for COVID-19 IPC, both at national level, subnational level, also management of IPC for COVID at the facility level. So strengthening IPC governance and management, improving healthcare workers and patient safety through rapid capacity strengthening in COVID-specific areas, such as IPC precautions, early recognition, triage, administrative controls, and going beyond health facilities, also reaching out to other workers such as ambulance drivers, morticians, cleaners. Also, we were focusing on improving healthcare management. And another important technical area was based on traditional MTaPS strength in supply chain management. We helped several countries to ensure uninterrupted access to the IPC commodities, such as personal protective equipment, waste management commodities. Next, please. So these are 13 countries where MTaPS implemented the first round of COVID emergency support that started in March 2020 and was largely completed by the end of 2020. We're still working in most of these countries, implementing GHSA interventions and helping with the COVID-19 vaccines introduction and Ebola response. And we'll be very happy to discuss these experiences at another roundtable. Next, please. For the most efficient COVID response, MTaPS tapped into its vast health system strengthening expertise, GHSA teams in the countries, and our historic strength in supply chain management. Our existing networks in the countries and good working relations with national counterparts were absolutely crucial. And of course, key to the efficient response were the talented people in the field and at the headquarters level. Centrally, we had a group of experts on standby, ready to respond to the country teams. We created an online COVID-19 hub for sharing technical resources, global and country best practices, and the knowledge and sharing. And we were accumulating this knowledge very, very quickly in the countries. We adapted the existing or developed new model COVID-19 guidelines or practical mini guides, SOPs, training packages, tools that were then customized to specific country needs. So in summary, it was a locally led response with global backstopping. These are some numbers. Next slide, please. This slide just shows some indicator numbers that we reported to the USAID Result Area 6, Infection Prevention and Control. We managed to train over 40,000 healthcare workers from 3,000 facilities, and 700 facilities were in compliance with the IPC requirements. Close to 700 facilities were reporting commodities stock data, which was very important for the emergency supply at emergency frequency, sometimes daily. And that informed rationing of scarce supply to avoid stockouts. Next, please. Now let's look at what approaches worked best for the response interventions. First, blended capacity building worked very well. It was a combination of face-to-face training of trainers, cascaded training done by both face-to-face and via e-learning platforms, and basically by every available tool, such as Zoom or WhatsApp. That all was supported by mini guides, SOPs that were readily available either online or on handheld devices or disseminated in print. And that was followed by supervision and mentoring. So it was really a combination of all available methods and tools for capacity building. MTaPS also established full e-learning platforms using open source Moodle platform in Burkina Faso, Mali, Cameroon, Kenya, Jordan. And we trained the country e-learning managers to and transferred these e-learning platforms and courses to the governments. In other countries where these platforms already existed, for example, in Philippines, Mozambique, Senegal, we enhanced these platforms with COVID, IPC, or emergency supply chain courses. Total of 29 e-learning modules were developed and handed over to the countries. And we hope there will be longer lasting impact as these platforms could be used to expand access to public health education way beyond COVID. Next, please. Continuous quality improvement. That proved to be very efficient for strengthening IPC practices, even in the emergency mode. This slide on your screen describes the approach and the tools we used most successfully in the Francophone countries, where we implemented a scorecard tool initially developed by WHO West Africa office. All facilities who implemented this approach improved their compliance with IPC standards. On your slide, you see the graph that shows improvements in Cameroon, and you will also hear today from Côte d'Ivoire and Kenya. Next, please. And the last important aspect, IPC commodities, such as masks, gloves, gowns. All these things are very crucial for healthcare workers and patient safety and for stopping the transmission of the virus. When COVID-19 arrived, national supply chains were not well prepared for the emergency, and many countries faced shortages of most needed IPC equipment. To avoid stockouts, scarce supplies had to be rationed, and that required efficient reporting of stock at high frequency, sometimes daily, for which existing systems were not designed. MTaPS has significant experience in setting up and managing supply chains. We will hear today from Bangladesh and Philippines experience on how MTaPS, working closely with the governments, helped to reconfigure existing logistics information systems and create new tools, dashboards for the mitigation of the shortages of IPC commodities. Now, this concludes my overview of the MTaPS COVID response. We will now proceed to our roundtable discussion, and we'll share our thoughts and experiences on what COVID-19 has taught us about IPC and emergency supply chains. But I would like to start first by introducing the roundtable speakers, starting with our esteemed guest speakers. From Bangladesh, we'll have Dr. Anindra Rahman, Deputy Program Manager, Communicable Disease Control, Directorate General of Health Services from Ministry of Health and Family Welfare in Bangladesh. Dr. Samina Chowdhury, Project Management Specialist from USAID Bangladesh. From Côte d'Ivoire, we will hear from Professor Nathalie Gassan, Head of the National Reference Center for Antibiotics, the Institut Pasteur of Côte d'Ivoire. From Kenya, we'll hear from Dr. Evelyn Wesangula, Head of the Division of Patient and Health Workers Safety and Antimicrobial Resistance Focal Point, Ministry of Health in Kenya. Joining them will be the MTaPS country leads, Mr. Antoine Diaye, Country Project Director in Côte d'Ivoire, Dr. Hasibul Haq, Country Project Director, MTaPS Philippines. Mr. Muhammad Abdullah, Principal Technical Advisor, MTaPS Bangladesh. Ms. Ninda Kusu, Project Director, MTaPS Kenya. And our two global experts based here at headquarters, Dr. Foza Alomba, GHSA and IPC Senior Technical Advisor for MTaPS, and Mr. Gashor Shifero, our Supply Chain Senior Technical Advisor. So very warm welcome to all of you. Thank you for joining this roundtable. So very good. Let's start round one. So we have first question here. And the question is, how did USAID MTaPS programs, ongoing GHSA work, and in-country presence help facilitate a rapid response to the COVID-19 pandemic? We will start with the MTaPS experience implementing IPC interventions. And I'd like to invite my colleague, Foza Alomba, to set up the stage for the IPC discussion. Foza, the floor is yours.
Thank you very much, Andre, and greetings, everybody. I'm happy to be part of this panel. Yes, as Andre has mentioned, the goal of the Global Health Security Agenda that MTaPS has been implementing around the world is to support participating countries to enhance their readiness to respond to public health emergencies and infectious disease threats like the one posed by COVID-19. Within the framework of the Global Health Security Agenda, USAID committed resources for MTaPS to accompany countries in 3 key areas of the antimicrobial resistance area of international health regulations. And these 3 are the multi-sectoral coordination, infection prevention and control, and the antimicrobial stewardship. So MTaPS's support to country responses to the COVID pandemic was largely based on the work that had been initiated to strengthen multi-sectoral coordination and IPC in these countries. Training structures that were developed within the framework of the MTaPS Global Health Security Agenda work, including pools of IPC trainers and facilitators, e-learning modules and platforms, and other training resources that had been developed earlier were readily adapted and used to enable a rapid scale-up of just-in-time training. One of the challenges faced by the global community during this pandemic was ensuring multi-sectoral coordination and scale-up of interventions, including infection prevention and control interventions within the context of a global shutdown. So countries that had existing structures to build on, such as functional multi-sectoral coordination committees, IPC technical working groups, were more prepared to face this challenge. As you will hear from the different country colleagues, countries with functional multi-sectoral coordination platforms and infection prevention committees were able to readily establish a coordinated and rapid response to the pandemic and ramp up in infection prevention and control training and monitoring. Thank you, Andre, and over to you.
Thank you, Fozo. You mentioned that IPC and multi-sectoral committees were already in place and were very important. Let's see how effective they were in the field. Let's now turn to the experience and field experience and hear from Antoine, the MTaPS Country Program Director in Côte d'Ivoire. Antoine, the floor is yours.
Thank you, Andre. Good morning, good afternoon, good evening. In Côte d'Ivoire, MTaPS has been working closely with the Institut Pasteur of Côte d'Ivoire, responsible for national coordination on AMR. So as Fozo just mentioned, substantial multi-sectorial coordination, AMS and IPC structures were already functioning. will leverage its links with national and subnational IPC and technical working groups and the resources under GHSA that were already in place for supporting health facilities visits to activate or strengthen the existing IPC committee and evaluating the IPC committee functionality and capacity using the standardized evaluation tool developed by the Ministry of Health, as well as the WHO tool, IPCAF, focused on IPC at the health facilities level. So all these existing pieces allow us to rapidly develop a set of activities to support the government response to the pandemic. The government and WHO relied on the existing IPC AMR technical working group to set up the IPC COVID-19 task force, and most of the AMR IPC technical working group members are very active in the COVID-19 response as members of the COVID-19 task force. So immediately after the first cases of COVID-19 in Côte d'Ivoire, MTaPS supported the IPC COVID-19 task force in conducting 2 cycles of IPC assessment using the WHO scorecard in health facilities. The score obtained from those WHO scorecard informed the development of action plan for each facilities. The members of the IPC committees were oriented on their role and responsibility and IPC standard precaution, and received tools for evaluating and reporting IPC activities as part as continuous IPC quality improvement, as Andre just mentioned. So MTaPS implements IPC activities based on the PDSI cycle approach, plan, do, study, and act. Initial evaluations were carried out in the supported health facilities. Action plans were developed and implemented. The capacity of health workers and IPC committee were strengthened, and regular monitoring is carried out with supportive supervision mission to assess the implementation of plans and propose corrective action which make it possible to revise the developed plan. So the strong leadership of our national counterpart at the Institute of Pasteur of Côte d'Ivoire in engaging members of the COVID-19 task force was a major success factor which allows the IPC COVID-19 task force to be a key actor in the national COVID-19 response and a reference on IPC at the national level. Thank you, and over to you, Andre.
Thank you, Antoine. As you noted, close collaboration with national partners was crucial. Let's hear from one of such important partners. And it's my pleasure to invite Professor Nathalie Guessin to take the floor. She will be speaking in French, and we will have consecutive translation. Professor, you're welcome.
Merci beaucoup. Bonjour et bonsoir à tous. Alors, comme le disait Dr Ndiaye, en Côte d'Ivoire, le groupe technique de travail a pris toute la mesure de l'importance de la coordination multisectorielle et multidisciplinaire pour faire avancer les activités du GHSA dans notre pays.
So Professor Guessin indicated that the AMR Technical Working Group understood the importance of multidisciplinary and multisectoral coordination to move GHSA activities forward in the country.
Alors, dans ce cadre-là, 2 comités multisectoriels ont joué un rôle essentiel dans la réponse rapide à la COVID-19, en particulier le comité PCI, qui était déjà fonctionnel et qui a mué en la task force PCI COVID-19.
2 multisectoral committees played a key role in the rapid response to COVID-19, especially the IPC committee, which was already functional and became the IPC COVID-19 task force.
Alors, en marge de ces actions du comité un autre comité, c'est le comité de gestion antimicrobien au niveau de CGTT-RAM, qui a initié donc un état des lieux de l'utilisation des antimicrobiens et pendant le COVID-19 et avant, en vue d'un plan de communication pour les populations et les professionnels de la santé. Et ce plan est en cours d'élaboration.
So in addition to these actions, the Committee for Antimicrobial Management within the AMR Technical Working Group started a situation analysis of antimicrobial use before and during the COVID-19 pandemic in order to develop a communications plan for the population and health professionals. And this plan is currently being developed.
Le programme de renforcement des capacités au niveau des établissements de santé, qui avait débuté avec les activités de la lutte contre la rame, s'est donc déployé et a couvert 18 régions sanitaires à l'intérieur du pays et à Abidjan.
The capacity building program at the health facility level that started with activities to combat AMR was scaled up and covered 18 health regions in the country and in Abidjan.
Alors, dans ce cadre-là, la Task Force PCI COVID-19 a fait un renforcement des capacités des comités PCI dans 17 hôpitaux régionaux, 4 CHU, 5 hôpitaux privés, ainsi que les capacités des agents des 13 sites de diagnostic et de prise en charge des patients COVID-19, avec donc la formation de plus de 1000 agents de santé en l'espace de 5 mois.
The IPC COVID-19 task force built the capacity of IPC committees in 17 regional hospitals, 4 university hospital centers, 5 private hospitals, and they also built the capacities of health agents in 13 sites for diagnostic and care for COVID-19 patients. In total, 1,000 health agents were trained in 5 months.
Alors, en dehors de ces établissements de santé, il a été également réalisé la formation des agents au niveau des points d'entrée du pays, en particulier au niveau du port d'Abidjan.
In addition to these health facilities, agents were also trained in points of entry of the country, such as the port of Abidjan.
Alors, comme vous le voyez, le travail accompli dans le domaine de la PCI RAM a contribué au renforcement des capacités des hôpitaux en PCI COVID-19.
The work achieved in the field of IPC AMR contributed to building the capacity in IPC COVID-19 of hospitals.
La formation de ces agents a permis donc d'optimiser l'utilisation du matériel de gestion des déchets mis à leur disposition.
The training of health agents helped optimize the use of waste management material provided to these health facilities.
Alors, toutes ces actions ont eu comme impact l'amélioration de l'hygiène et de la prise en charge de ces malades.
All these actions helped improve the hygiene and the care of patients.
La riposte rapide a été possible donc grâce à la coordination qui était déjà mise en place avec le soutien technique et financier de MTaPS dans le pays.
This rapid response was possible thanks to the existing coordination that was implemented with technical and financial support of MTaPS in the country.
Malgré ces avancées, notables dans la lutte contre la rame, avec le leadership des GTT RAM, sous la coupole de la plateforme SOS Santé, beaucoup reste encore à faire.
In spite of significant achievements in the fight against AMR, under the leadership of the AMR Technical Working Group and of the One Health platform, more still needs to be done.
Les défis à relever donc vont porter sur le renforcement du cadre législatif et réglementaire qui devrait soutenir les actions du GTT RAM, l'élaboration et la validation de documents pour encadrer ces actions, la poursuite du renforcement des capacités des comités PCI et comités médicaments, mais aussi la poursuite de la formation des acteurs de la lutte contre la rame.
Challenges include strengthening the legislative and regulatory framework, supporting the actions of the AMR Technical Working Group, the development and approval of documents to oversee actions, continuing to build the capacities of IPC committees and drug committees, as well as continuing to train stakeholders to combat AMR.
Alors, la réussite de telles actions nécessite que fédèrent les différents partenaires dans la mise en œuvre du plan d'action de lutte contre la rame, d'abord au sein de notre gouvernement, mais aussi avec nos partenaires au développement.
Achieving these different actions requires strong collaboration between partners in implementing the AMR National Action Plan among the government as well as among implementing partners.
Alors, à vous, je vous remercie. Merci.
Thank you for your attention.
Thank you very much, Professor. Côte d'Ivoire seems to be a great example of how collaboration around GHSA interventions came in handy for COVID response. Also, as was mentioned, continued collaboration between the government and implementing partners was very important and should continue. Let us now move from West Africa to East Africa, to Kenya. And I'm inviting the MTaPS Country Project Director in Kenya, Ninda Kusu, to share her experiences. The floor is yours, Kusu.
Thank you, Andre. Good morning, good afternoon, good evening, everyone. When Kenya announced its first case of COVID-19 in March 2020, like many other countries, Kenya was ill-prepared to contain the virus. Health facilities were not equipped at all to handle an influx of COVID-19 patients, and health workers were not trained on COVID-19 specific infection prevention and control measures, waste management, including how to use personal protective equipment, which was in short supply and overpriced at the time. Under the global health security agenda work, MTaPS had been supporting containment of antimicrobial resistance with a focus on multisectoral coordination and antimicrobial stewardship and infection prevention control at the national level, county levels since June 2019. And MTaPS Kenya COVID-19 response focused on COVID IPC management, waste management practices, capacity building of healthcare workers to recognize and isolate suspected COVID-19 patients, and the application of IPC precautions to keep themselves and patients safe. So MTaPS Kenya leveraged its in-country presence, IPC expertise, networks, and partnerships to quickly respond to the pandemic. MTaPS in Kenya employed a systemic and a whole market approach to capacity build and to bolster institutional and human resources capacity. We were able to leverage our AMR activities and also diverse collaborations to reach various target audience with COVID-19 IPC trainings, with the job aids that we developed and IAC materials, and even compliance tracking for good IPC practices and requirements. Our main collaborators included the Ministry of Health, Council of Governors, counties, numerous private sector and community setups, such as the faith-based organization, and examples include the Kenya Conference of Catholic Bishops, the Christian Health Association of Kenya. We also collaborated with the Kenya Health Federation, health professional associations such as the National Nurses Association of Kenya, Pharmaceutical Society of Kenya, to mention but a few. And we also collaborated with the youth development networks, such as the Youth Empowerment Development Network. On the development space, our COVID-19 response partners included the World Health Organization, CDC, UNICEF, Kenya Red Cross, and USAID partners. For example, the Human Resources for Health, Kenya, to mention just an example. So in a nutshell, our antimicrobial resistance infrastructure in Kenya really came in handy to put those relationships to work and scale up our COVID-19 interventions across the country. Thank you, and over to you, Andre.
Thank you very much, Kusu. What stood out for me is that the diverse partnerships that the MTaPS Kenya team was able to operationalize as part of GHSA work, and that became tool for an effective pandemic response. Let's now hear the perspective on COVID response from our government counterpart in Kenya. And I'd like to invite Dr. Evelyn Besangula to take the floor. You're welcome, Doctor.
Thank you, Andre. Good morning, good afternoon, good evening, colleagues. It's a pleasure to be here to be able to share our perspective in terms of the response that we had to COVID-19. And I really just want to build on to what Dr. Kusu has spoken about, because really a lot of our response did not just begin at the onset of the pandemic in March, but we already had a working relationship with our partners and MTaPS in particular for a very long time, supporting antimicrobial resistance programs and infection prevention and control programs at a country level. So one of the things that stood out in terms of response at the beginning of the pandemic were the existing structures, which we were able to actually leverage on the structures that had been set earlier and the partnerships. And these structures had been set by our policy space. We already had a national IPC program, we had a policy, we had guidelines. Together, we had already developed training packages, and we had an enabling platform that brought together all partners supporting infection prevention and control through our National Infection Prevention and Control Advisory Committee. So it was easy for us to transition, even during that emergency response, coordinating structures at a national level to provide guidance for the National COVID Task Force, and also provide a lot of guidance under the Infection Prevention and Control Subcommittee, which fed regularly to the National COVID Task Force. So because of that platform that had already been created for engagement, we had a quick response. And MTaPS also was able to respond very quickly to country priorities and plans, because we developed plans at the beginning. And the good thing is that these plans were jointly developed through the IPC subcommittee on COVID-19. And that actually helped to activate action across all levels, from the national level to the county, right to the facility. Through the partnerships, we were able to very quickly, at the beginning of the pandemic, develop relevant training packages now aligned to COVID. We already had some for IPC, but now tailoring this to COVID. We were able to develop COVID-specific guidelines, SOPs, job aids, which we were able to disseminate at all levels, not just within the healthcare space, but also disseminate these documents to the non-health sector. For example, the media, we also had engaged security teams who were also able to engage the youth, like she rightly said. Early on in the pandemic, through their collaboration, we were able to develop assessment tools, assess quarantine facilities at the beginning and isolation centers. And this really helped us even in the review of our guidelines on how to establish isolation and quarantine facilities. So we saw a lot of our healthcare workers trained early on in the pandemic. And again, because of their quick response, we were able to quickly reach more than 30 counties, train more than 2,000 healthcare workers within the early stages of the response, which made a big difference in terms of supporting the implementation of infection prevention and control interventions. So I value the relationships that had been established right to the facility level. So what that means with the engagement and the partnerships, we're able to follow through in terms of supporting, monitoring and evaluation of the interventions. So some of the key things as I conclude, maybe just to bring up the gaps. We did not have enough resource allocation. If MTaPS had more resources, we would have had broader coverage that would have made more impact at a country level, but we appreciate the level of support that was actually provided. And in terms of what we have learned actually is that there are 4 things that are key when it comes to responding effectively to the pandemic. The existing systems, how well are partnerships able to build on the existing systems, which we're able to do very well with our MTaPS partnership. Number 2, the structures that exist in a country, are they enough or are they even there we were able to build on the structures that we had already established, even if they were not 100% functional. But with the partnerships, we strengthened them more, and the facilities and counties were able to respond better. Number three, the existing policy environment. Because we had already created a policy environment, the MTaPS was able to plug in to the processes and effectively support the government priorities and plan in good time, because we already understood this before the pandemic. So the existing policy environment provided a very rich ground for us to do the work with authority and with a lot of confidence, because the mandate for IPC was clear. And finally, strong partnerships that consistently fed into each other and leveraged on each other's strengths, just like Kusu has said, working alongside other partners and bridging the gaps like MTaPS did, where other partners were not able to build capacity. MTaPS was quick to step in and support capacity building, printing of material, the whole distribution and follow-up. So those four lessons, I think, have come out very strongly for us. And apart from that, of course, advancing the agenda on antimicrobial stewardship throughout the pandemic process. So we appreciate the partnerships that we have had. And because of that good working relationship, we continue to respond to this pandemic in a very effective manner. And of course, strengthened systems. And it's not just a reaction, but actually building on the system so that they are resilient and can be able to withstand future challenges that we face. Thank you very much. Andre, over to you.
Thank you very much, Dr. Wesangula. It's really impressive to learn that how Kenya responded to COVID challenges, and how this response was based entirely on existing networks, existing strength of partners, of GHSA multi-sectoral coordination, and that allowed reaching out to very wide audience, actually going even beyond health facilities. That's a very interesting and important experience. Now let's switch to another very important technical area, which is supply chain management for pandemic response. Before we start with that, I'd like to remind you to please put your questions in the chat. With this, I'd like to invite my colleague, Gasho Shifero, to introduce this technical area. Thank you, Gasho. The floor is yours.
Thanks, Andre, and good morning, good evening, or good afternoon, everyone, wherever you are. Unlike the IPC, we didn't have a GHSA kind of intervention for supply chain. It was pretty much a new territory, I think, for everyone. But out of 14 or 15 countries, MTaPS has supply chain system strengthening activities in two countries, in Bangladesh and the Philippines. And it was really very helpful understanding the country supply chain landscape, the existing supply chain systems, how activities are coordinated, even if there is any lack of coordination. That was really very helpful to figure out what should be done in responding to the pandemic. We, as Andre mentioned previously, we developed online assessment tool also for supply chain, and conducted that rapid assessment to each and every country, taking MTaPS's presence and an understanding of the country's situation as an opportunity to come up with key interventions. But besides the normal supply chain system strengthening activity we have been doing, while the basic supply chain or the conventional supply chain principles apply for emergency responses, we know that there are critical elements that wouldn't be the same as a conventional supply chain system strengthening activity. The first one is time. Time is very critical during emergency, be it in a pandemic like COVID, or even a natural disaster. Actually, the first 72 hours are life-saving moments. Also, time not only just to respond in a quick turnaround, but also things are changing rapidly in a short period of time, literally every day, which means that demand for supplies are unpredictable, changing every time. The other challenges we faced was totally different from the regular supply chain, was the global supply chain disruption everywhere, and global shortage as well of life-saving IPC commodities like gloves and masks. So faced with these challenges, we had to relook at our approach and the possibility of introducing changes to respond to the challenges, which is a pandemic. You will hear more from countries like Philippines and Bangladesh on those changes and how we responded to the pandemic. To add on that, the emergency supply chain playbook developed through the USAID GHSA investment for Ebola emergency preparedness was really instrumental to reinforce the concepts and adapt it to the response phase. Because even though the playbook was developed for preparedness, we didn't have a time talking about preparedness. We didn't have a time to, even the resources to have stockpiling and so forth, simulation. So we need to adapt it in a response phase. So that was very helpful, not only just in countries where MTaPS has supply chain system strengthening activities, but also in other countries like Jordan and Mozambique to use and adapt that concept in responding to the pandemic. In summary, I would say our country presents the system strengthening activities we have been doing, as well as the USAID GHSA playbook concepts helped us in facilitate the response for the pandemic. Over to you, Andre. Thank you.
Thank you very much, Gasha. As you said, times of key essence in pandemic response. Just one day without personal protective equipment may result in continuing transmission and lives threatened. Let's see how the MTaPS teams responded at the country level. Let's look at Bangladesh. I'm inviting MTaPS Principal Advisor Mohammed Abdullah to share the Bangladesh experience. The floor is yours, Mohammed.
Thank you very much, Andre. Colleagues and friends, good morning, good afternoon, good evening around the globe. USAID MTaPS program here in Bangladesh started its work with the goal of a strong pharmaceutical system and to contribute to the government of Bangladesh sector program objectives and its commitment to achieving universal health coverage. Like other development partners, MTaPS program came forward to provide technical assistance to the government of Bangladesh, especially to Directorate General of Health Services during this pandemic. We initially started working with DGHS in the area of infection prevention and control. Simultaneously, the MTaPS team conducted a rapid assessment on the DGHS existing supply chain management functions. The major findings of the assessment was to have an urgent need of a tracking and reporting system to monitor COVID-19 commodities such as PPE, sanitizer, mask, to avoid stockouts and readjustment of supplies among the health facilities. We initially developed an online daily reporting system in the existing DGHS portal. MTaPS virtually trained over 600 users around the country to start using the system. In the first week of April 2020, the reporting rate was 75, which was gradually increased up to 98%. All the stakeholders, including the UN agency, World Bank, and other development partners, started using information from this portal for their procurement planning and emergency supplies. Later in September 2020, MTaPS Bangladesh enhanced the system to capture all real-time transaction data like receipts, issue, donations, consumptions, stock balance, and also introduced a simple customized forecasting tool for the health facilities, which is called COVID-19 ELMIS. And now in Bangladesh, in the health sector, everybody knows about this COVID-19 ELMIS. The MIS unit of GHSA has taken the responsibility for monitoring and tracking the stock situation and scaling up the system nationwide gradually. So we feel there is a full country ownership of COVID-19 ELMIS, and GHSA especially is getting benefit of it. Thank you very much to all. Over to you, Andre.
Thank you very much, Mohammed. Bangladesh is an interesting example of how systems could be adjusted very, very quickly, provided that a good base exists for normal supply chain systems. Let's have the government perspective on the challenges and solutions that were offered by MTaPS. We will hear from Dr. Aninda Rahman, Director General of Health Services. Dr. Aninda, you're welcome.
Hello, good evening and good morning to some people, I guess. Thank you very much. I'm very happy to be here, especially it's because for last 1.5 years, I'm working very closely with MTaPS. My program is working very closely with MTaPS. As already shown, I work in the Director General of Health Services under Ministry of Health and Family Welfare. And the time is short, so I'll talk very briefly. The first corona case in Bangladesh was identified in March, I guess 8 March. And even before that, when the COVID pandemic started in different parts of the world, we started working on it and we started planning what to do in case of COVID pandemic. And we prepared a Bangladesh preparedness and response plan. It was in March, the early March, I guess. And after that, I think MTaPS started working with us in COVID. Before that, they were working with us in AMR. But after this situation, they started working in COVID as well. And they provided technical assistance in emergency supply chain, as already mentioned by Mahmoud Abdullah, and also infection prevention control activities. Although I'm not supposed to talk about IPC, I guess, in this question, but I was more involved with IPC work with MTaPS. And I was very happily collaborate with this collaboration. So there was, in our preparedness and response plan, there was a pillar called case management and IPC pillar. So MTaPS was involved in this pillar. They were part of this pillar, and they actively participated in both IPC and case management, and obviously the emergency supply chain issues. So I think Mahmoud Abdullah already mentioned many things about the emergency supply chain. But if I may, I would say a few things, like they worked on the rapid emergency supply chain stakeholders mapping and also the preparedness assessment. That was very important. And it was a multi-stakeholder assessment. They also implemented the IPC and PPE commodity tracking system. There was a huge crisis of PPE in that first period of time, and they helped us in that situation. They supported quantification exercises, and obviously, as Mahmoud Abdullah mentioned, they developed ELMIS for our COVID-19 commodities. And it was a very interesting thing because in Bangladesh, we were very weak in this sector in ELMIS, but they did it in a very short time. Also, not only this, they worked for capacity building, especially in this ELMIS sector. They provided lots of training to lots of stakeholders or lots of relevant people, relevant managers in, I guess, more than 500 facilities, and also some the online training of those kind of things were also done. And they also developed some videos, I guess, for this system. And last but not the least, as I already mentioned, that I worked on IPC closely with MTaPS. So I would like to say just one or two sentences regarding on that. They helped us providing training to lots of participants. So it was about, they had, I guess we trained about 20,000 people, 20,000 healthcare workers on IPC, and they provided supported on at least 5,000 of them. They MTaPS provided supporting us. So it's a really amazing thing from them. And they provided us support in developing some videos on IPC, developing the guidelines, and also doing IPC assessment on different facilities. I think I'm already out of time, but I'm working closely with MTaPS for last 1.5 years. So I had lots of things to say, but maybe if time permits some other time. Thank you very much, Andre.
Thank you very much, Dr. Rahman. It's really enlightening and inspiring to see the very close professional partnership and collaboration between projects, partners, and the government. Thank you very much for this perspective. We're lucky to have yet another key stakeholder's perspective on Bangladesh experience. We will hear from Dr. Samina Chowdhury, project management specialist from USAID mission in Bangladesh. Dr. Samina, the floor is yours.
Thank you, Andre. Can you hear me?
Yes, loud and clear.
Yeah, good morning and good afternoon. Good morning and good evening. After the very eloquent speech from Dr. Anindya Rahman, I think I have less to talk about, but nevertheless, I would like to point out some of the issues. First of all, I would like to mention 3 things that worked very well because of the presence of MTaPS. First of all, the 3 things are: first, early response; second, effective collaboration and coordination with the government and other stakeholders; and third, appropriate approach. So how could we, why am I mentioning early response? You see that at the during 2020 March, when the pandemic started, there were lots of challenges for the government. One of the challenges, as was mentioned by Dr. Anindya Rahman, that the commodities, management of the commodities, lots of commodities were coming in, both from donated sources, and also government was procuring. But there was, we need to have an idea of the stock, and also there was issues related to equitable distribution of those commodities. So we need to act. We meant the government and also the development partners, we need to act. But why USAID came in this supply chain part, that might be the question. That was because that Ministry of Health knew that USAID's MTaPS had the capacity, and also they had the acceptance, especially in the supply chain area. They worked for years, so they had the capacity, they had the acceptance, the team had the acceptance. And that acceptance and reliability helped us a lot to act early. And we worked on the already developed system, that was the supply chain management portal. And the MTaPS team had very good network with the DG Health store system, like the divisional and district warehouses. Though it is not as developed as the DG family planning ones, but they started working with them and they had very good network with them, and that helped that helped MTaPS people to go to reach out to them. And they developed a very simple, I mentioned appropriate approach. So they developed a very simple system so that everybody can adopt that, and they can train them through telephone or through online communication. They could reach out to 600 facilities. And as Mr. Abdullah was mentioning that from April, 70% of the facilities started reporting on their stock status. And then the issues of collaboration and coordination. As Mr. Anindo Rahman was mentioning, one very good thing Bangladesh did, there was a national response team, and they had 8 pillars. That they developed 8 pillars, and this was a great thing done by the ministry and the DG Health, and they had a portal in DG Health's website, and each of these pillars worked with some of the development partners and also some of the government officials. As you would see that Dr. Anindo worked very closely with us. So with the development partners, when we worked in the logistic pillar, we had great acceptance from all of the development partners, and they accepted our intervention and they supported our intervention. And we got very good support from the Director General of Health Services, from MIS department, from Director Hospital, and so that they were instructed. They got letters from written instructions from the Director General of Health Services to report on that stock system, and it was tracked, and it was shown in the dashboard, in the COVID dashboard of the DG Health. So it was a great initiative, and I must thank the Ministry of Health and also the Director General of Health Services to work very closely. And we had a very, I should say that exciting environment that we worked together, like for example, Dr. Anindo and the MTaPS team and us, we worked even in the late nights, we were working and developing the guidelines. And it was, when I remember that what we did 1 year back, I always get excited that yes, we did a great thing. So thank you very much. And I hope we will work together and Bangladesh will always be an example. Thank you.
Thank you very much, Dr. Samina. I really liked your recipe to successful addressing of COVID challenges: early response, effective collaboration, and appropriateness of approaches and interventions. These are 3 most important principles that underpin the success. Thank you very much. We'll now move to a very different region, and it's my pleasure to invite Dr. Hasibul Haq, the MTaPS Country Project Director in the Philippines. The floor is yours, Haq.
Thank you, Andre. So good morning, good afternoon, and good evening, everybody. So as you heard, like the experience from Bangladesh, I think we had also had like a similar experience and similar challenges. So in the Philippines, the MTaPS program is like the only procurement and supply chain management systems is strengthening project. So when COVID came, then yes, people came to MTaPS that, okay, what support we can provide, because supply chain is a big issue. As Kasha was explaining, there's a global shortage, there's uncertainty about projecting how many cases will be there, how much commodity we'll have, and how we distribute, okay? So those are the challenges, okay, the Philippines faced, and the local mission, okay, reached out to MTaPS actually to say that, okay, whether we can actually help the Department of Health in addressing the challenges. And so thankfully, yes, we got the support, and then we were able to support in the Philippines. So our presence there, and with the knowledge of this like a local supply chain management, as well as our global knowledge, actually was really, really useful to handle the situation in the Philippines. So that's one thing, like we knew the challenges, we knew the system, and we knew, okay, how to address that, but it was not easy. Like we said that the challenge is, yes, there's a global shortage and the country was trying to procure the personal protective equipment, and country was trying to get some donations, okay, from different sources. So things are coming in bits and pieces from different sources, and that needs to be allocated and distributed to avoid the stock out of the personal protective equipment. Like we talk about the IPC, but also there's a correlation between like a compliance with IPC and availability of the personal protective equipment. So in the Philippines, actually, we came up with a simple solution. It's like that when WHO and others like is struggling to project the what will be the pandemic, and then projection in information is changing very quickly every day, sometimes very high, sometimes low or something, and the government is like struggling how much to procure. But it's not just planning, because there's uncertainty how much they can procure and when the commodity will come to the country. And then it comes to like the allocation and distribution. So we came up with a very agile system. System is like for the different type of health facilities, which is actually treating the COVID patients. You have a pretty standard number of healthcare workers there, and a number of shifts, they are expected to work. So a healthcare worker, when like it doesn't matter how many COVID patients are there, they would need to protect themselves. That means the demand for personal protective equipment in the health facility, you can actually pretty much predict from the number of healthcare workers and number of shifts they will be engaged in working, and disregarding number of patients they are treating, because the patient's requirement is different. And based on that and type of health facility, there's like we develop a system for it's like a supply chain management tracker. And then tracker can automatically predict like how much commodity will be required, and for next 7 days or 15 days or 1 month. And then depending on what is available at the central level, you can actually automatically distribute them according to the equity and the need. So if you have like a more supply, you can distribute like a 2 weeks or even 4 weeks. But if you have less supply, you go for 1 week and then wait for the next supply to come. And that was the practical solution that country came up with, because you cannot apply those standard, regular distribution practice. And by using that, actually country could avoid any major stock out of the personal protective equipment, till today. And another is the country actually was using a bed tracker, the mobile phone based application that is actually on a daily basis, like a reporting how many hospital beds are occupied by COVID. So a hospital actually doesn't matter what is the total COVID patients in the country, they would not be able to go beyond their capacity. So that means based on this like a use of the hospital beds, you can also actually estimate the need for commodity to be supplied to the hospital for treating patients and the other commodities. So that actually worked very well. Another is during this pandemic, yes, the emergency supply chain was an issue. And due to the travel restriction, we cannot actually keep like a face-to-face training. So we developed the e-learning courses, and then DOHS, Department of Health, they have this like a DOH Academy, which is an e-learning platform. And that came handy, and that was actually developed by another USAID implementing project. And so that is HRS 2030. And we use that, and then we put our course there. But we also, through webinar, train around more than 15,000 healthcare workers on infection prevention control, healthcare waste management, as well as supply chain management. That came as handy. And apart from that, it was actually handled by national task force, as other speakers, they talk about the need for coordination. We also placed one consultant there at the national task force to coordinate the supply chain management issue. And that was actually also highly appreciated, and that was very useful to make those supply chain decisions. And that actually helped the country to avoid any stock out and handle the situation. So that's the Philippines experience. Thank you. Over to you, Andre.
Thank you very much, Haas. We are a bit short on time, so we will try to move faster to have more time for questions and answers. This concluded our round 1 of discussion. And our round two consists of basically two summaries made by Dr. Foza Lomba and Gasha Shifiro. The question to discuss is what approaches and tools developed or leveraged by MTaPS for COVID emergency response proved to be more efficient, most efficient, and could and should be institutionalized to improve health systems resilience and prepare for future challenges. So I'd like to invite first Fozo with his IPC takeaways on future preparedness. And please, Fozo, 2 minutes for you. Thank you.
Okay, Andre, thank you very much. And I want to say we have heard that the approaches and tools that were developed during the Global Health Security Agenda implementation were readily available, but MTaPS also developed innovative tools in response to COVID-19. So I'll focus my discussion on the key takeaways with respect to IPC. And the first one is that focusing on strengthening the core components of IPC at the national level is important as a foundation of IPC in the country. However, the COVID-19 pandemic revealed that it is even more important to invest in preparedness at the facility level. This must include preparedness at all facilities, because when the pandemic struck, patients did not have the luxury of choosing which facility to go to. My second takeaway will be that in facilities where the fundamentals of standard IPC precautions were already established, it was easier to implement updates and just-in-time training without the need to hold up health workers over long periods of days for training. Countries were able to use the e-learning platforms to rapidly scale up a remote training to reach more health workers. So we think that establishing e-learning platforms as a health system strengthening approach and emergency preparedness should be considered by countries. One of the areas that will need greater focus as facilities build IPC programs is triage for IPC reasons. We found that to be lacking during this emergency response. There will need to be protocols developed and training on, triage at the facility level for IPC reasons. That's something that we need to be integrating in our global health security agenda work. Another area of weakness that will need to be strengthened is surveillance of infections amongst healthcare workers. Earlier on in the pandemic, we found out that this was quite an issue because many health workers got sick, were not immediately diagnosed, and some health systems almost collapsed because of that. So that is something that we need to be paying attention to, surveillance of infections amongst healthcare workers. And during the pandemic, the separation lines between the facility and the community in terms of IPC was blurry. So we're thinking that it's important for some national coordinated effort to be made to develop some protocols to be used during pandemics or outbreaks to control infections from the community to the facility and from the facility to the community. And also, it is important for countries to invest in creating a cadre of IPC professionals. This cadre will have a career profile, and they will be the ones that will be supporting both IPC work in the facilities, but also emergency preparedness. And lastly, from the global point of view, the fact that we had a coordinated, a hub at the home office in MTaPS really helped, because not only were we able to develop tools at this hub and distribute to all the countries, but we were also able to take resources from other countries and share with the countries and share knowledge and experiences during the pandemic. That proved to be really efficient. Thank you very much, Andre, and over to you.
Thank you, Fozo. These are very valuable insights. Let us move to supply chain takeaways. And Gasha, you have 2 minutes. You're welcome.
All right, thanks. I will highlight 4 key takeaway message from our experience for the last, I would say, 14, 16 months. I think the first one is having a clear, comprehensive supply chain preparedness and response strategy. It's like a playbook that I have mentioned before, but adding agility to it. For example, understanding the challenges, the time factor, and then the global shortages, the quick reconfiguration of the inventory policy, and then the distribution policies in the Philippines is a pretty good example to get prepared in the future. Preparedness obviously saves lives. And also preparedness, according to the study by UNICEF and WFP, it saves a lot of money. It reduces the amount of response fund by twice. So that strategy, defining the goals, balancing the supply chain response and efficiencies, really important. The second takeaway message is having an innovative approach. The tools that has been developed in the Philippines and in Bangladesh that enhances supply chain visibility, even for the future, be it regular or emergency, having that visibility will optimize the inventory holding at any level. It's just like replacing inventory with data. If we have data, if we can see the data, we don't have to hold inventories in every place. We can optimize that. So that's a good example. And it's getting traction right now to add more products into it. The Bangladesh one, they are very much interested to expand it to more commodities. I saw one question is if there is a possibility of to include more products. Yes. The commodity tracking system, which was linked with the surveillance system in the Philippines, also getting traction to expand it to the vaccine supply chain. The third one is communicating changes very quickly. You have seen that the changes happening in 2 countries specifically. Data was being captured every month previously, but it's happening every day in Bangladesh. This is a huge change. So we need to communicate that change quickly. Also the same thing with other countries. So be it e-learning platform, actually in the first phase, because developing the platform takes time, using Zoom, WebEx, training many health workers on the changes, not only just building their capacity, but also communicating changes is very important that we need to think moving forward. The last one, the fourth one, is coordination, the whole government approach. Not only just to take the leadership, the coordination, but also to leverage resources, mobilize resources. It's a huge, complex situation when it comes to resources. The good example again, the Philippines case where the resource and logistics task group, which were directly reporting to the president's office, you can see the commitment from the leadership. And it was even easier for us, as Has mentioned, to embed a consultant to the task group so that we can provide that technical assistance. So these are the 4 takeaway messages, the lessons that we have learned. Over to you, Andre. Thank you very much.
Thank you, Gasha. This concludes our round 2. We have some time left, less than we actually wanted, unfortunately, to respond to some of your questions. And I will probably read the question and then ask someone to respond. There's an interesting question. To what extent can the system developed in Bangladesh for COVID response be used for broader set of commodities, for example, for essential medicines? And directing this question to my colleague, Mohammed, Abdullah from Bangladesh. To what extent can the system developed in Bangladesh for COVID be expanded to a broader set of commodities like essential medicines?
Thank you, Andre. This is a very good question because the development and emergency system is not that much hard, but sustain the system and for the long term, it is a challenge. But fortunately, this time, DGHS felt and DGHS realized that they should have a broader ELMI system covering all of their commodities in the health program. Accordingly, they are seeking support, technical assistance from USAID through MTaPS. And in our work plan, this year work plan, we have an activities to enhance the existing system covering all the health commodities in the health program in Bangladesh. So maybe within next one or 2 years, DGHS will have a broader ELMI system to cover all their commodities. Thank you.
Thank you very much. We have another question, actually the topic that we did not address, but it may be interesting. I would like our counterpart in Kenya, Dr. Evelyn, to address it. The question is it possible to address how the country addressed the home deliveries and communication challenges with providers and communities during the COVID?
Okay, thank you very much, Andre, for that question. I think one of the ways we were able to address these challenges for like home deliveries and also the community aspects during the pandemic, apart from just working through the structured systems, working from the national level to the county level, right to the facility level, we also engaged other professional associations and also the private sector to continue to build capacity for healthcare workers so that they're able to address challenges right to the community level. We also had doctors that came up with innovative solutions that are able to support just the best practices to continue being offered and implemented at all levels right through the pandemic. So we didn't just focus on what the government could do, but we also looked at what other professional associations were able to do through their vast membership that spans throughout the country, right to the community. We're able to deal with other partners that have very strong community health programs to be able to address the pandemic at the community level. The mainstream healthcare workers could not address certain challenges. Thank you. Over to you, Andre.
Thank you very much. My next question will be to Dr. Rahman. Dr. Rahman, you are in kind of between supply and IPC. So the question is, can you shed some light on the connection between better availability of PPE and compliance with IPC protocols?
Thank you very much. I think you already mentioned rightly in the question that these two are very much related. As I already mentioned in my time, that when the COVID pandemic started in Bangladesh, there was a huge crisis of PPE. And the crisis was not only because we didn't have PPE, but we didn't have a proper system to, distribute them where those are needed. And that was a big problem for us. And it was a big challenge. And with the help of MTaPS and some other development partners and our experts, we mitigated that situation. And IPC is not only for COVID, so it's going to be a continuous work because it works for any infectious diseases, right? So I think this kind of thing like IPC, the required things, not only PPE and other things, other materials for IPC, all of these things requires planning. It may be central planning or something like this. So this kind of central ELMIs will be very much crucial Like if we can plan from the central, like where the requirements, what are the requirements, where we should put them, those kind of things, then it becomes very much easier. So these things are very much connected, and I think your question have the answers, I guess.
Thank you very much, Dr. Rahman. I think we can take one more question. And I'd like to address this question to Antoine. Although the question was asked about Bangladesh, but it probably pertains to all countries. And the question was, make some comments about the capacity building mix in-person versus e-learning, how this worked in your experience.
Yes, thank you, Andre. I think that it was really important to have some, let's say, field follow-up. And I think that there is no maybe comparison to do between the e-learning and the face-to-face capacity building in the field. So I think that here in Côte d'Ivoire, it was very good to start with very intensive capacity building activities. And what we did here in Côte d'Ivoire, which was very good, is from the start, we really build our work on the local aspect. And they are the ones really who set up the stage. They are the ones who really develop all the material that was needed to provide those capacity building. And now to really have some sustainability, we also support the country to develop some e-learning platform and really use those platforms also to follow up with the training. So it was really a complementary approach using capacity building in the field and e-learning approach. Thank you.
Thank you very much, Antoine. We will have to close the Q&A session. Unfortunately, we're running out of time. We have only 2 minutes left. And in those 2 minutes, I'd just like to make some closing remarks. So today we tried to look at what basis GHSA and supply chain management interventions done before COVID help for better COVID response. And the second question was what approaches, tools, and innovations that were developed during COVID could be mainstreamed or should be mainstreamed into general health strengthening. We heard from colleagues and partners from Côte d'Ivoire, from Kenya, from Bangladesh, from the Philippines. So what did we learn so far? That first, global health security agenda interventions work and must be accelerated. We now see that what was slow in normal implementation can be actually done in a very accelerated manner. So we also see that all investments in IPC, they really pay off in every way. And IPC capacity building, again, must be accelerated beyond normal GHSA pace. We learned that curricula for IPC should be enhanced to include more aspects like triage for IPC reasons, not just patient reasons. Facility-based and community-based IPC should be integrated. Supply chain systems, we learned that they are not fully prepared, but where investments were made previously into pharmaceutical system strengthening, in those countries like Bangladesh and the Philippines, systems can be really, rapidly adjusted to emergency response. With this, I'd like to complete our webinar. On the slide, you see our contact information. Alexis Leonard, unfortunately, she couldn't join us today. She's our CR at USAID. Prime contractor for MTaPS is Management Sciences for Health, and we also invite you to visit our website. And with this, I'd like to thank you, all participants, all speakers, esteemed guests, friends who joined us and patiently listened to the webinar. I believe you have many, many more questions. We'll be very happy to respond to your questions through our country teams, through personal emails, and through other opportunities, other webinars. Thank you very much. And until next time, thank you.